have David, who is staying in the hot seat. And with him is, now I have to find these in alphabetical order. We want to actually thank both Deborah Cohen and Perry Dixon, who have joined us from Deborah, who is a professor, and she's the vice chair of research in the Department of Family Medicine at Oregon Health and Sciences University. And really delighted to have you with us today. And then Perry Dickinson, who is a professor in the Department of Family Medicine and a director of the department's Practice Innovation Program and the Colorado I Can Talk Health Extension System. So all involved with this work, and we're pleased to have all of you with us today. So David, are you going to kick it off?
Okay. So thank you so much, Beth. And for all of you, the slide says this is an update on evidence now. Forget that. That's not what this is. This is a 90-minute session. It's a little bit longer because this is we're back to you saying, what's next? We need your advice on the bigger question.
So it's evidence next, not evidence
exactly.
now.
And it's really about AHRQ's role in primary care. And what are the opportunities? Who are the potential partners? What are the high leverage opportunities for us? And to understand where you think we should go, we wanted to make sure you understood where we are right now. This is really, really exciting work. It's some of the most exciting work I've gotten to be involved in my career. Because of the subject, it's primary care, and it's really directly changing the lives of Americans, but also the amazing group of people that have pulled together. So I'm extremely grateful that Deb Cohen, as you heard, from Oregon, and Perry from Dickinson from Colorado have flown in to help give you a really robust picture of what we're doing here. So the goal here is to give the NAC and anybody watching an overview and an update on this project, what it is, and I'm going to do that quickly at the beginning, what we're learning from our national evaluation team that Debbie's going to tee up for you, and then go deeper into the field and really understand what it's like on the front lines, both of primary care, of the changing landscape of healthcare in America, and also in this research and transformation support activities that Perry is really not just in evidence now, but across some other programs that he'll tell you about, really on the cutting edge. And then, as this slide gives you the correct thing, is really use that as background for your discussion about AHRQ and the future of primary care. So, the origins of evidence, how we got here. And I'm going to tell you about three different streams that led to this program. The first was Million Hearts, a program of the Department of Health and Human Services to save 1 million heart attacks, to prevent 1 million heart attacks and strokes within a 5-year period. An ambitious national effort bringing together public and private. And the department came to AHRQ as they were putting this together and said, what's your role, AHRQ? And we responded immediately and said, well, we're about healthcare systems. So while our colleagues leading this at CDC were focused on public health approaches to prevention of heart attacks, we wanted to understand and help with the role of the healthcare system in primary and secondary prevention of heart attacks. As we were doing that, AHRQ received through the Affordable Care Act, beginning in 2011, funds from the newly created Patient-Centered Outcomes Research Trust Fund. That's a mouthful, but the PCOR Trust Fund. And specifically with that, Congress instructed AHRQ that we were to use this money for innovative dissemination of new PCOR knowledge that's been generated. And AHRQ right away said, you don't really just mean dissemination, because just telling people about the evidence isn't what it's about. We're going to take this funds and invest it in disseminating and helping people implement, use the evidence to improve health and healthcare in America. Two streams, and the third stream clearly was AHRQ's commitment to primary care. We believe at AHRQ that a primary care health system is the foundation to a national healthcare system, not nationalized, but to a system that delivers healthcare to all Americans, that's high quality and safe, that's efficient and effective, that decreases disparities. All of our goals for American healthcare are based on a strong foundation in primary care. We've been engaged in this work since we were founded. These are samples, and you can later go back and look at some of the different areas that we've worked on in primary care research and also direct support of primary care practices. So with those three ideas, aligned with Million Hearts and the idea of decreasing primary prevention of heart attacks and how the healthcare system can work in that. A requirement to disseminate and help people implement evidence to improve care, and a focus on primary care. We put those together and created Evidence Now. What it became through the creation of these 7, and we'll tell you about these regional cooperatives, providing external quality improvement support services to small and medium-sized primary care practices, which often don't have the internal resources for quality improvement activities. To provide those externally to help them implement the evidence on the ABCS and therefore improve the heart health of their patients, but simultaneously build their capacity to understand and use evidence moving forward. And as we did that, so our 2 goals: directly implement the evidence of ABCS, and that's aspirin use, blood pressure management, control, cholesterol management, and smoking cessation support services. We wanted to deliver those services. We wanted to see increases in that. We wanted to change primary care practices that we touched, leaving them stronger than where they started. And finally, again, because this is AHRQ, we wanted to study how this kind of external support helps primary care practices improve both how they work, what they deliver, and learn so that we can share with the rest of the healthcare community how to build and disseminate what works to help primary care practices. Partners for that future work could be CMS, it could be Blue Cross Blue Shield of Michigan, it could be newly forming ACOs who wanted to understand. So many people need this information now. So Evidence Now is not just about the evidence for those practices, but the evidence the healthcare system needs to improve. This is one of the largest investments in AHRQ's grant history, $112 million over 4 years. We launched in May of 2015 after a year of consultation, collaboration, and development of this. The awards created 7 regional cooperatives to do this work, and I'll tell you that their challenge was not only to deliver this care, but to research how to deliver this care internally. And then we said, because they are testing slightly different interventions, we wanted to build that roadmap. We needed a national external evaluation. Traditionally, those would have been done by contract. And we recognized this information would be so powerful, we didn't want anybody to turn around and say, well, the government invested this, they're just proving that what they did was good. We wanted an external independent evaluation, so we did this through a grant mechanism. And we were thrilled by the applications we received and to award a contract to Oregon, and this team led by Oregon, to look across the 7 grantees to paint a picture of what we're learning nationally. We also invested in a National Technical Assistance Center, and I'll tell you a little bit more about what they're doing, but to knit this whole project together. Our goal was to reach over 1,500 small to medium-sized primary care practices that currently don't have quality improvement support service or available resources, which would reach over 5,000 primary care professionals serving over 8 million patients. And I'm happy to report to you now that we've done that part of it, and we'll tell you what we're learning from this. Here's the map that shows you the 7 regional collaboratives. The regions can be as small in geography as New York City, not obviously small in populations, or as large as the Pacific Northwest with Washington, Oregon, and Idaho in one team, and scattered across the country. Some people have pointed out that an effort to work in heart health really needed to touch the stroke belt, and this map actually shows, or could be looking to say it doesn't, we missed that goal. And I would actually say, no, we have it. North Carolina is the beginning of the stroke belt, 5th highest rate of strokes in the US, and Oklahoma is actually the end of the stroke belt and is the epicenter of some of our problems. It's the highest level of disparities for heart attacks and strokes in the country, number 2 overall. So we do actually have some of the greatest need areas in the country, as well as the diversity. When I say external practice support, people say, what do you mean? So this is what AHRQ meant. These are 5 evidence-based services that have been shown in smaller studies to change how primary care practices work. On-site practice facilitation and coaching is the linchpin for this whole program. It's getting elbow to elbow with these practices to help them on their journey, meeting them where they are and customizing the services to their needs. The other kinds of supports that the cooperatives are providing include health IT and data use, local shared learning, helping practices learn from people like them in their communities, occasionally expert consultation when there are questions that the academic health center has answers to, and bringing those resources to these primary care practices, And like everything at AHRQ, we're about data and feedback and benchmarking to drive change. People say, but what do those facilitators do? This is a list, it's not exhaustive, but the kinds of things they do is teach practices about quality improvement methodology and facilitate their developments of teams. They're there on the grounds with people, delivering the evidence and making sure they understand it, but also then thinking about what does that mean for their workflow and how they practice can improve efficiency, because often change, there's no room for it till you make a little bit of space. And so meeting practices with efficiency is one of the ways they do that. And then towards the end, you can see that it's also about making them part of a community of improvers, both locally and nationally. To understand if this program was working, we made a decision to standardize the metrics, or a set of core metrics that would be used across all of the programs. We did that across all three of our goals. So the ABCSs of performances of aspirin, blood pressure, cholesterol, and smoking collected at baseline for all of these practices and routinely as they moved forward. This is not the data they're using to improve. This is the data for the research to show the change over time. We also said we wanted to be able to understand, did we help the practices grow? So we needed to measure there, and we decided to call it practice capacity using some validated surveys. That costs money, that costs time. That is not what these practices wanted to do. So we funded this program, and part of the reason why it's a very large program is because we're paying them to help us collect that data. We're paying the cooperatives to collect it, and we're having them help either provide the resources or provide the incentives to get us that extra level of data. We also realize this is all about context. The real learning comes from understanding how these practices are developing in contents. And so there's mixed methods evaluation, looking at the internal change and capacities and context of these practices, as well as the regional collaboratives context and what's happening around them. These are the four measures that they were used. They're all, or three of them are NQF, and the fourth one, CMS endorsed measures. Lots of learning about this, but just know they're standard to start with. As I said, our goal was to really learn. Each of the cooperatives is a research grant. They are doing independent evaluations of their work. They're really robust and interesting and different. And then on top of that, as you're about to hear about, we awarded this contract to sum up across them, to think about themes and learnings, and to really be able to say what works for whom in what situation and build this roadmap. So no small task. We actually started this whole program after we awarded the grants by telling the national evaluator, as well as the 7 cooperators, this is impossible, but we have faith in you. To make it a little easier for them, we created a National Technical Assistance Center. They're creating learning opportunities across the grantees, the 7 or 8 grantees, web portals and newsletters, and interest groups focus on problem solving. Also providing direct technical assistance for problems, often around data collection issues or methodological questions on how do you best organize a step wedge design when randomization didn't occur, and how are you going to do analytics? When we need those kind of experts, the tech can bring that. They're also helping AHRQ tell the story of what we're learning moving forward and creating what we hope will be a robust set of resources, a national learning hub after this program of the blueprint and all the things we learned. The TAC is helping us do this. We are not doing this alone. This is, AHRQ is very committed to doing this in partnership with our federal partners. So we meet with them regularly, sort of as an informal steering committee for this program to make sure we're aligning with the work of CMS and CDC and NIH, and that they're learning from what we're doing, and we're taking what they're doing and making sure we're aligning it with where the cooperatives are moving. As I told you, this launched in May of 2015. We've been out in the field. They recruited their 1,500 plus practices and did baseline data. They're all now actively intervening. We're actually just past the end of year 2. Some of the first practices have finished their intervention, and they're getting in the maintenance phases and the post-intervention data collection phase. That will go through the fall, and in the spring, all the last data collection will happen. Data gets turned over to the national evaluator. The National Evaluators Grant actually goes an entire extra year to keep processing the learnings from this, but our question for you is, we can see that finish line coming. What's next for them and for AHRQ? So right now I'm going to turn it over to you, to the real experts in this, to go deeper. By the way, I'm from New York, if you didn't hear. I can talk really, really fast. I'm happy to answer questions, but I think it's going to be more important to you to hear from them to fill this out. So first from Deb on the national learnings from the National Evaluator, then Perry going deep. But before I do, here are the questions I want in the back of your mind. How should AHRQ build upon what we're learning and what we've done? How do we think about what you heard from Gopal earlier of the Secretary's priorities on opioids, mental health care, and child obesity as AHRQ thinks about primary care in the future? And a few other questions, and I'll bring these up in the end, but about how do we align with things that you know about that are happening that we need to know are happening? Are there other issues in primary care that are the burning platforms that AHRQ needs to be addressing now? Okay? So with that, put these away.
Thank you for inviting me to come here. I'm excited to talk about what we learned so far in the national evaluation, and David has been kind enough to cover some territory so I can move through some of this a lot faster. I've divided my talk into 3 different parts. I'm going to talk a little bit more about the evaluation approach, share some early findings, and then talk a little bit about some next steps or implications of those findings. Oh, great, thanks, that's great. So the first part is to talk a little bit about methods. As David told you, we're doing a mixed methods evaluation. A couple of our aims look at, and we're using the ABCS data. One of the things that David didn't mention, and I think you would agree, is that the choice of the CMS ABCS measures, in my opinion, really created an overlap between the same metrics practices would use for quality improvement with the metrics that we're using for research. And that just is a place where I like to work, because we're very much aligning, maybe not with the quarterly look back periods, but we're aligning what we're looking at with what they're working on. And that's been very interesting. So a couple of our aims focus on baseline data and understanding patterns of ABCS delivery at baseline and practice capacity at baseline. In addition, we've been conducting a prospective observational analysis, and our goal is really at 2 levels. The first is to understand these regional cooperatives as organizations, what the components of them are, how they develop their partnerships, and what they do. And the second then is at the practice level, which is how are practices changing? What are the characteristics of the practices that are influencing change in ABCS? And then specifically in this year, we're turning our attention to taking a deeper dive, to selecting a sample of high change and low change practices, and really going deeply into understanding what explains practices that change and improve and those that don't. And finally, a 4th goal of our work, in addition to understanding the combinations of the intervention that are most effective, is to rapidly disseminate these findings. So let me just quickly review some of the data sources that we have. Adaptive reserve is one of our capacity measures, and that's being collected through a practice member survey. We have a practice survey. We get one for each practice that looks at structural characteristics of the practice, and also our second capacity measure, which is looking at the strategies the practice is using for quality improvement. Intervention tracking is perhaps one of our most interesting pieces of data. So the facilitators that are working with these practices in the field are tracking their touches, the number of touches, the type, the duration, and that is going to be very important data along the pathway to change and to help us understand why some practices may change and improve and others might not. We have data from ABCs, and we learn a lot about the EHR, which I'll talk to you about. And we're also conducting a cost survey, which is looking at the cost of actually implementing the external support at the cooperative level only for these practices. So what does it cost a regional cooperative to provide support to 200 primary care practices in its region? Our qualitative data is also pretty extensive. It starts by reviewing documents such as grant proposals and other documents that the cooperatives create. We use something called an online diary where we interact over time and in real time with the cooperatives to understand their implementation experiences as they unfold. It's a really useful rapport building and data collection tool. We've been invited and allowed to be participant observers in work group discussions. We visit the site visits, the cooperatives every year, and that includes both observing what they do and interviewing folks. This past year really focused on external support and practice facilitation. So in every cooperative, we went out with a handful of facilitators to see what they did when they worked with practices and then interview them, which was amazing. As I mentioned, this year we're going to be doing practice site visits where we'll go out to practices and talk with them about what their experience was with Evidence Now and take a look at what they've changed. And that includes both observation and interviews. And then when we need to, we just get on the phone and call folks. We've developed, I think, a pretty nice relationship with the cooperative teams. So this is one of our co-leads for the qualitative team, Sarah Ono, on a site visit in New Mexico, actually. And this is the website that we've created for rapid dissemination. It's called escalates.org. So now I want to turn and talk to you a little bit about what we've learned so far about the Evidence Now practices. So as David mentioned, the cooperatives have been wildly successful in reaching their goals. They've each recruited at least 200 primary care practices. It's funny, I had somebody review my notes and they put in here a comment that what I'm presenting here are data as of May 18th, 2017, which for those that work with us, know we keep our data pretty up to date, and folks on my team thought you might think this is a little old, but it's pretty current. I find that adorably funny. It's great. So approximately 93% of the practices in Evidence Now report fewer than 10 clinicians in their practice. Almost 70% of the practices report having 5 or less clinicians. 68 of the practices report that they're located in an urban setting, but you can see that there's really good representation of rural and suburban practices. Almost a third of the practices are serving patients in medically underserved areas. And almost 40% of the practices are clinician-owned, again, with good representation across ownership types. So I wanted to tell you a little bit about the Evidence Now cooperatives. And I really love this map because the dots on each of these each of these dots represents a zip code where a cooperative has recruited at least one practice. And what's really nice about this is that you can see that in a number that they've spread from border to border in their states. And oftentimes in health services research, the folks that participate in this work are the usual suspects. I mean, I'm the first to say these are sometimes the practices that are closest to the academic institution. And this is really not the case. And I want to point out that this really ties in, and I'm going to leave Perry to talk about this, with the idea of the healthcare extension. These folks have extended their relationships and built trust with practices and reach that is impressive. And I'm sure many of you are familiar with the healthcare extension. It was an unfunded mandate of the ACA that was built on and analogous to the agricultural extension. And it's sort of a auspicious moment to think about it because the agricultural extension was helping improve the farm work in our country at a time when food was very expensive and worries that it was going to be scarce. And you can draw analogies now between the healthcare system, with healthcare being very expensive for folks as well. So the healthcare extension is really poised to help practices. So let me tell you a little bit about what these cooperative extensions are doing at a very high level. And I'm just going to touch on 4 ways that they're helping practices. First, they're helping practices identify performance gaps. Compare their data to external benchmarks and set targets for and monitor performance improvement. They are helping practices learn about current evidence from experts where that's necessary, and then learning how to implement clinical changes to improve care quality to align with that evidence. They're helping practices develop motivation, capacity, and resilience to make changes, to respond to environmental changes and external reporting requirements. And they are developing a broader and more connected network of community partnerships to better serve practices and their patients. Just want to give you a sense of what a couple of these look like, and I'm going to go through these rather quickly. This is the Northwest Cooperative. It's a 3-state region of Washington, Idaho, and Oregon. And you can see the partnerships that they've brought together. The lead is Kaiser Permanente, and that's where the evaluation is being run and where the whole project is being overseen, but they've partnered with Qualis Health, which is a regional extension center and a QIN, as well as with a practice-based research network, ORPRAN. And both of those organizations have provided the boots on the ground, and in this case, the health IT expertise and the practice facilitation and coaching expertise to extend themselves to the practices. They were also instrumental in leveraging their relationships to engage practices in this work. Quickly, and in contrast, this is Oklahoma. Oklahoma is a single state region. I'm just going to highlight some of the differences in the partners that they've brought together. So in the Northwest region, there is no health IT data infrastructure per se in that region. Oklahoma is a little bit different. They have an emerging health information exchange called MyHealth, and part of their work of Evidence Now was expanding the reach of MyHealth and getting more practices connected. Instrumental in that was their relationship with their regional extension, because those connections aren't so easy to make. They needed the regional extension to work on the ground with the practices to connect them to this data resource and frankly, to extract data by other means when they needed to get it faster. In addition, their PBRN has also been involved in this work, although it's not pictured here. They have developed a lot of relationships with county and community partners. So they have a mission of getting a community health partner located in each region that partners with the academic health center, and they've been doing that through their community health improvement organizations. And those are folks that work with members of the community and make links to the practice and also to the academic health center. So what are they doing to help practices? They're providing data infrastructure and health IT expertise. They're providing practice facilitation and coaching, offering expert consultation, offering online learning opportunities, creating learning collaboratives, creating peer-to-peer learning opportunities, engaging communities and patients. And they're also creating the content delivered through these modes. So I want to take a little bit of a deeper look into three different areas. The first is I want to talk a little bit about burnout, and these are all baseline data. So we thought about practice capacity in Evidence Now, thanks to AHRQ, in 4 different ways. I'm going to just talk about team member burnout today. So as we were working with the cooperatives to harmonize the measures for the surveys, we agreed on including one burnout measure in the practice member survey. So this is a survey that's completed by everybody in the practice or multiple representatives from the practice. And this is the question. We've looked at it both as a dichotomous and a continuous variable. And essentially what we found is that, on average, burnout was about 1.9, which is in the I'm feeling stressed but not burnt out range. But this is an average, and as you can see from this diagram, there are practices with higher and lower levels of burnout. Part of what the opportunity here is for cooperatives is to identify and understand what's going on with burnout in these practices. And as Perry's going to talk with you maybe about, is to help them understand where the problem is manifesting and, if at all possible, how to address it. So we have a few clues for potentially where to look and how to think about that. So these surveys were filled out by 8,699 practice members. And what you see here is that overall, 20% reported burnout. Physician burnout is the highest at 25.7%, but over 20% of nurse practitioners and physicians' assistants were also reporting burnout, as well as 17.6% of non-clinical staff. When we looked at some of the correlates with higher burnout, we've aligned this with Maslich's framework for burnout. What we found was that being a part of a non-solo practice, being a part of a health system, and participation in ACOs was associated with reporting higher levels of burnout. The number of hours worked per week, longer time in practice, and practicing in a rural location were also associated with burnout. Participation in programs like Meaningful Use, and again, ACO participation. And this lack of community connection, which we think may be part of practicing in a non-solo practice in a health system own practice, seems to be associated with folks reporting higher levels of burnout. So there's definitely more to be learned here and interesting things to be done. So the next area where we've got some initial findings is around data infrastructure And this, by far, has been one of the greatest challenges for cooperatives, in my opinion, in the first 2 years of Evidence Now, and is therefore one of the greatest opportunities. So again, recall we're using clinical quality measures from CMS, right? A, B, C, S. 3 of these, A, B, and S, were been part of PQRS reporting for quite a while. So we asked practices some questions about their EHR use. Interestingly, 90% of the practices were on EHRs. Predominantly, these practices were using ONC certified EHRs as of 2014. There are 68 different EHR systems represented across the cooperatives, 68, and very wide variation. New York City has only 4 EHR systems, for example, and some are supporting as many as 32. Approximately, I don't know who that is exactly, but it might be right here. Approximately 60% of practices have participated in both meaningful use stage 1 and 2, and nearly 70% of practices report that they have no one in their practice that can use the EHR to create a clinical quality report, although 40% have somebody outside of the practice that can help them do that. So I just want to kind of review what we think are some of the data requirements for quality improvement. So clinical quality measures for the EHR must reflect current guidelines. The cholesterol measure, which there was a new guideline in 2013. I believe that the value set for that guideline was released in May of 2017, and it's that value set that drives whether or not an EHR can produce that CQM. So from 2013 to 2017, which meant none of the EHRs in this particular Evidence Now could produce that clinical quality measure. Practices have to have data that is credible and trustworthy. The reporting measurement periods must be customizable, which means that they need to be able to be changed so that they can align with a PDSA cycle. Reports need to be adaptable to the level of the practice, the clinical team, right? This is where we see these bright spots in our clinical teams and want to spread them across the practice or across the system. Folks need to be able to look at that data that way. And they need data at the patient level to inform their visits and to inform outreach and registry work. And data need to be comparable across EHRs and practices. And here is where we've seen lots of opportunities that EHRs do not meet practices' data needs for quality improvement. And I could talk about this for hours and hours, but practices had not looked at their meaningful use data reports, that although participating in meaningful use was associated with practices being more likely to say they could produce a CQM report, they hadn't looked at it. When they were pushed to look at it by their cooperatives, they didn't find those data valid. They had no way of then using a report to figure out how to validate that data. And a lot of EHRs didn't actually allow their practices to manipulate their measurement period. So they could only get reports for a year, from January to December. And that is just not the right period of time for quality improvement work. Health system affiliations seem to help with this, but what we learned qualitatively was that health systems don't get their practices, their reports, or the data they need very rapidly if they're not aligned with health system priorities. So a lot of cooperatives ran into trouble there. The data infrastructure does vary regionally and can help mitigate these challenges, although I'm not going to go into detail here. In Oklahoma, the HIE can help. In New York City, they have data warehouses and that kind of infrastructure that's building connections with these EHRs that can then provide practices with the functionality they need. But in Oklahoma, as they've been trying to build this, they found it's very expensive. They've gotten charged, and I just checked this with Dan Duffy, anywhere from $5,000 to $15,000 to make EHR connections to do this. So this infrastructure is necessary, but what we found is it's not sufficient, that each of the cooperatives has had to have boots on the ground to get in there to find out what is going on when the data that's in the EHRs is not valid for quality improvement. And I'm just talking about quality improvement. We can now all take it up a level and think about the implications of using these data for research. But we should start at the ground level. And then finally, and I'm sure I'm wildly over time, but these data, again, are incomplete and not totally up to date, but it's all of the practices for which we've got baseline plus 3/4 of data. And what you can see here is that this is working, that these practices are making changes over time. Keep in mind that these ABC measures, they report quarterly with a 12-month look-back period. So we wouldn't expect to see huge wild changes. We'd actually expect to see the kind of incremental changes that we're seeing over time here. In terms of next steps, I'm going to leave practice capacity building completely to Perry. In terms of research, what is so great is the size and the number of practices in this initiative, because I think the HIT and the EHR challenges are the perfect example where every practices individually across the United States have been dealing with this problem. I mean, we have a paper just on the cusp of getting out. Folks wrote about this problem in 2008, but when we've got 1,500 practices dealing with this at the same time, it lights it up in a whole different way. In addition to that, there are a whole bunch of really important questions to answer around practices' experience with implementation support, the extent to which practices actually sustain this kind of work, the impact of clinician and staff turnover and other disruptive events, which I know I didn't talk about, but they are present, on the ability to change and improve. And in fact, disruptive events seem to be associated with as there are greater number of disruptive events reported in the last 12 months, the practice also reports using fewer QI strategies. I think there's work to be done with what's really going on with burnout. These are all practices that agreed to participate in a heavy lift QI initiative, and 25% of the clinicians report burnout. What are strategies for accessing and reporting data and now in the future? How do we make the data infrastructure better and more actionable for smaller practices? How are practices using data they now have available about practice performance and why not? How do practices adapt to becoming an employed practice, which is happening a bit in here, and really at the center of what you've been talking about, what infrastructure and support do practices need to adapt into learning systems? And I think Perry is going to talk about this because that's really where the cooperatives are working. This is our team. They are amazing, and thank you.
That was a sprint.
Yes, and I'm from New Jersey, so I too can talk fast.
I think we should finish because I fear that we'll never get to Perry. So
And you really want to.
You really want to.
I want to get to Perry. So, and I trust you all to remember enough of what has been said by Deborah to come back to her. So.
Yeah, we'll get this straight. Okay, let's see if I can get it going back. Yeah, there we go. So I'm not going to spend a lot of time on specific data from our results from our cooperative because I think Deb hits the bigger picture better. I'm going to hit just a couple of highlights around evidence now. And then I'm going to really talk about the on-the-ground aspects of doing this work, both from a implementation perspective, but also from a research perspective, what AHRQ's role is and can be in this, and how that compares to the role of other funders like CMMI or in NIH and others. So just to give a little bit of context about Evidence Now Southwest, it's a collaboration between the New Mexico Health Extension rural offices and the Colorado Health Extension System. So you'll see two different programs that are kind of building out as fully formed extension centers, and we'll talk a little bit more about that in a moment. New Mexico really has had a long history of focusing on local community health efforts, and particularly with underserved populations in their extension work, but not as much experience with formal practice transformation efforts. In Colorado, we have had good grief, probably a 17-year history of doing practice transformation efforts. You know, we were one of the early places where that works actually started with practice facilitation, et cetera. But not as much with the community-based work that New Mexico was doing. And both of us were trying to build something that was more comprehensive across the two. So it made for a very, very natural partnership between two groups that know each other and work together anyhow. Both of us had also, just historically, a strong practice-based research network background in both states. So that's kind of building on that expertise and moving it forward. So in Evidence Now Southwest, 211 practices, 53 in New Mexico, 158 in Colorado. These are actually the practices that engaged. We actually had 234 who enrolled, but had a few who dropped out before they actually got fully started for a variety of reasons. And you'll see where really are, the target for Evidence Now was reaching some of the smaller, more independent practices that didn't have a large infrastructure. We're doing that. In Colorado, we're averaging 3.8 clinicians per practice. In New Mexico, 2.4 clinicians, MD, DO, PA, or nurse practitioners. So, and it's spread quite a bit around rural, urban, suburban, you know, the whole mix, as you'll see in a moment. Oops. Yep. Let's just do this. Okay. So as Deb said, it's not just the usual suspects. And this is interesting, I think, from both someone who's done a lot of PBRN work and other sorts of research work. This is an incredibly diverse group of practices. In Colorado, we've done a lot of practice transformation work historically, so a lot of practices we had really engaged previously in work, and we're actually working with them in other projects. But this Evidence Now was incredibly helpful to us to engage some practices that were actually new to practice transformation or research into this work. Across both states, it allowed also the engagement of new partners in this work and the development of a new enhanced infrastructure for practice transformation, community engagement, and implementation research. We're seeing improved alignment and coordination of efforts across these multiple partners. I'll give you a case that's a little bit of an example of how it's working in Colorado in just a moment. But that the bringing everybody to the table who's involved with supporting practices actually helps us to accomplish aligning things and coordinating things from the practice perspective, which is just, it's very, very important. One of the things that's burning out clinicians and practices is you're hit with so many different things with different terminology from different directions. And I have to say, from my perspective in the state of Colorado and in New Mexico, the development of these partnerships and the infrastructure may be the most important outcome of on the regional level of Evidence Now, as long as there's some ongoing support, hopefully. So I'm going to talk specifically about the Colorado Health Extension System. This is a multi-stakeholder collaborative that's convened by the University of Colorado Department of Family Medicine. It includes over 20 what we're calling practice transformation organizations that provide transformation support for various groups of practices in Colorado. Now this is a diverse group of organizations. It includes health systems, hospital systems that own practices and are providing support to them. They're not as engaged in Evidence Now because we weren't going for system practices there, but across our larger efforts, they're pretty critical to engage in this work. It involves practice support organizations like the Primary Care Association for the state that's supporting the FQHCs, and a number of nonprofits in the state. Health Teamworks, which historically has been doing a lot of this work for years nationally and in Colorado. Groups like that. So a wide variety of different organizations. And also, I should mention the quality, the information exchanges as well, the health information exchanges. A number of the state agencies, this is done, several of our projects are done in partnership with the Colorado's Governor's Office, the Department of Public Health and Environment, our Medicaid office, and the AHRQ in the state. And then a whole bunch of local nonprofits. So it's a wide-based cooperative. There's not a real formal structure here, and we've actually tried to avoid creating another organization to do this. We've been able to maintain it as a cooperative. From the impact study funded by AHRQ earlier, you can see the 4 states in the slightly deeper blue, New Mexico, Oklahoma, North Carolina, and Pennsylvania, but then also the partner states for those that have started extension work, and it has expanded beyond this, but this is just from impact. So this is something that is occurring nationally and has extended beyond this considerably, and in particular with Evidence Now, you can see Evidence Now as an extension of this work. So our mission, and I want to go over this because it's important to understand the different facets of the work, and I think this is shared across most of the extensions. To improve health and health care across Colorado through supporting innovation, quality improvement, and transformation in primary care. It used to be just primary care. Now we're extending it out much more, particularly through TCPI, to specialty practices as well. Improving practice readiness for new payment models through technical assistance and infrastructure development. Promoting local collaboration among primary care practices, specialty practices, other healthcare providers, community groups, patient advisory groups, local public health officers, and public health agencies. There are such silos on the local and regional level, and the more we can get people working together for dealing with these problems, the better off we feel like we will be. Facilitating and aligning local or statewide efforts to improve health care and achieve the quadruple aim. And then producing new knowledge through careful evaluation of every program that we put into place, and by linking research institutions and researchers with practices and community partners through the linkage with the universities in the state. So this really started through partnerships through improving performance and practice, one of the early large-scale practice transformation efforts. We were one of the two initial states for that. The Beacon Project, I did the evaluation for Beacon, but then grew into this larger partnership around the time of the Impact Grant. And we were partnered with Oklahoma for the Impact Project. We used that for a small amount of money to actually get before that it was completely voluntary. At that point, we actually had funding to support a project director, project manager. And then we had this big burst of 3 big grants. Evidence Now, a CMMI-funded state innovation model project that we're taking on in partnership with the Colorado Governor's Office that actually focuses on behavioral integration and alternative payment models, working with 400 primary care practices. And then Transforming Clinical Practice Initiative, we're a practice transformation network for that project in partnership with the Governor's Office, where we're primarily working with systems and specialists. What we have with that is a whole range of projects where we can support different types of practices for slightly different types of work. We're providing a little bit of an on-ramp to practice transformation for different types of practices, which I think is important. And just recently we added on to that an opioid use disorder project in partnership with the Colorado Office for Behavioral Health, funded by SIMSA. I am not going to go through this because I think David and Deb generally dealt with all of this really well earlier. The one thing I do want to put in there is that we identified from our previous work that the whole thing around the getting data out of the EHRs for this project was going to be a huge headache. And so we had, drawing from the Beacon project, the evaluation we did there, we developed a workforce that we're calling clinical HIT advisors with some specific roles that are separate from the practice facilitators. They have just a little bit more expertise around data extraction and EHRs to work with the practices in kind of hand in hand with the practice facilitators. And we have an additional role that we're fielding that we're calling a regional health connector. And this is where we can get into more of the connections with the community. And we're funding this across several projects. Their role is to be a local person employed from the local area who's a connector in the community who can support practices by engaging with the practice leaders, helping to assess their needs and linking them with resources, staying in touch with the practice as they go across multiple projects, because this is a journey. It's not one project that gets them where they need to go, but they can stay in contact with the practices longitudinally. And connecting the practices with the public health, behavioral health, and other community resources that are present in the community that the practices are oftentimes very, very isolated from. And then also collaborate across community partners to identify and assist with community health priorities, and then really moving into social determinants of health because they're linked between the community resources and the practices and can actually help move things in that area. This is worth talking about. We've been doing a whole range of transformation projects, and we see it in this sort of range. Implementation projects, where we're just going out and working with practices largely around implementation. There's not a strong research component, but every one of them, we try to do very careful evaluation so that we learn what's working and what's not. We've done a lot of evaluation of other folks' implementation projects early on, the Beacon Project, or Improving Performance in Practice, and others, and we've learned a lot from those. So those two kind of go together. Workforce projects, we have to do building the workforce, and we've done residency PCMH, curricular and practice implementation project, a large-scale project there, and we need to get into the PA, the medical assistant and nursing training programs much more, and are trying to move that direction. Community engagement projects that are interfacing with practice transformation, like, for example, a project where we pulled together a diverse community group to provide input on patient resources for diabetes management. And so that feeds directly into then what the practices can implement. Up to clinical trials about especially interesting or difficult areas. They're always emerging from our evaluation efforts of these other projects, things that we're just continually cracking our heads against. Patient self-management support is an example. That's very difficult to get into practice. So we have an NIDDK project investigating implementation of self-management support for patients with diabetes. All of these use, no matter what the project, uses a mix of research, quality improvement, and evaluation methodology, and they're all a mix of qualitative and quantitative. I mean, that's become a universal approach. Challenges. The huge challenge, and the evidence now really, really helps us with, is the need for a large number of practices for these studies. The subject of these studies aren't individual patients, it's practices. And while you can do a study with maybe 36 to 40 practices and get some significant results, you can not even get close to some of the more textured and finely detailed sort of learning that we need to get to, that it requires much larger data sets. And so evidence now has been a huge blessing in that area. Implementation projects of this type takes a lot of boots on the ground, and they're expensive. You have people out working in the practices. You can't do this often, very much of this from a distance. A huge challenge is that it takes time for practices to change and for the changes to be reflected in the measures. Things like blood pressure control. I'm actually a little astonished that we're seeing improvements in blood pressure control because it just takes time, particularly as you're getting the measures in, before the changes that you're making in a practice get reflected there. And you really have to, as you start this work within a state, and we're seeing this in New Mexico compared to Colorado, you have to build momentum in engaging practices in this work. It's interesting working with New Mexico, who's earlier in the course of this, some of the issues we hit 10 years ago with getting practices to where they will accept meeting and learning collaboratives and learning communities and kind of building off of that. They're just coming along, whereas we've kind of gotten a little bit past that. And then just the major data issues. The time to where I had a slide in here that I guess I took out, but the time to get a practice to where they actually trust their data. Actually, they tend to trust their data a little more coming in, and then it goes precipitously down, and then slowly comes up, but it is, the data is not trustworthy. And so anything that we're doing relying on clinical quality measures as the key outcome is just until we have a better mechanism for supporting the practices in this, it's just going to be very rough. And that's across all types of practices. It's not just the small isolated. So the role of AHRQ in this work. And I think AHRQ has a unique position to focus studies on this sort of thing. The real-world implementation of evidence and guidelines. the process of practice and health system transformation. What works, when, how, and for whom. And again, that requires large studies, unfortunately, that are hard to get funded elsewhere. What should high-functioning systems and practices look like? How can practices serve, and this is really critical, how can practices serving rural and kind of focused, underserved populations adapt and survive, and as we're moving into these advanced models that don't always take into account the sort of infrastructure that those practices have in place. And then how can health extension systems like we're trying to build serve as connectors for research institutions with practices and communities, both assisting in and learning from the implementation and adaptation of evidence in the community, but also engaging the practices and communities and identifying their local needs for research. I think AHRQ is, in my experience, the only funder that really covers these critical areas. And other funders, CMMI certainly is funding some large-scale practice transformation projects. Their evaluation efforts tend to be a little bit separated out from the implementation process and is a little bit more narrowly focused. And I won't say that they're not interested in more nuanced research questions, but it's just not it's not within their scope particularly. NIH, obviously, it's not been impossible to engage them in some more broad-based practice primary care research. I've done it, but there's such a limitation on some of the acceptable methods, and the narrowly focused institutes just really put a crimp on that. And so while they are a source of support, it's minimal compared to AHRQ. And foundations. I've used foundation. I'll take funding, as is probably clear. In order to build this work, I'll take funding from anyone who wants to fund these sorts of projects. There are a lot of foundation projects sprinkled in through this history. Typically, what you can do with them is they'll fund implementation projects, sometimes with very limited evaluation. You put a little kernel of evaluation in there and expand it out and learn from it. But you have to avoid using the R word with them. So AHRQ is critical here. So just a quick thing on my conclusions, at least. There's still just major questions regarding how to assist practices in implementing new knowledge and to make the changes that are being required in the healthcare system. There's such a major changes underway in the health system, and primary care is at the core of those changes, but we don't have a lot of evidence to guide what's happening there. I think we're developing new expanded laboratories that really build on previous PBRN work, but go further, that can aid in the generation of this needed knowledge. And it requires large-scale implementation projects that blend quality improvement, evaluation, and traditional research methods. And with that, I'll stop. Thank you.
Well, thank you both. That was tremendous, and I'm sure we have many questions. I'll just say in kicking off while people are putting their tent cards up that I'm sitting in a very large health system, Kaiser Permanente. I resonated with almost everything you said, and I actually do think sometimes and I'll bet David in the VA resonated with a lot of what you said, and so I think there are opportunities to learn across all of these different kinds of setting, and that most systems that are trying to learn and improve are dealing with many of the same issues. I mean, I think it would be a mistake in some ways, except for some of the perceived resource advantages, to dismiss those concerns as being unique to small practices. And I think the question is how we all work together to overcome some of those barriers to sort of learning and improvement. So, okay, that was not, so Lucy.
Thank you. Great work. I was really happy to see that you mentioned the QINs and the AHRQs. Mm-hmm. And I would be curious, as you're doing the evaluation across the cooperatives, to try and almost establish like a playbook. Like, what do you get from different kinds of partners? Mm-hmm. Especially, depending on sort of the distribution, like North Carolina is a very rural state, and AHRQs have been very strong there. And what do they contribute? Mm-hmm. And I know in my HEN work, the QINs were, sort of overlapping, because I'm thinking towards sustainability. Mm-hmm. So I understand you have a program of research and you're looking to continue it, but once a practice sort of drinks the Kool-Aid on quality improvement, are you seeing it bleeding out into other topics and areas? And one of the ways that I've found success, and this is largely through work I've done as a faculty member at IHI, is helping people to understand how do they capture the cost of the cost savings of the improvement to help sustain that. And then across the cooperatives and the various practices, what does it cost to maintain the analytic support needed to continue to fuel that engine? And what can you learn from that so that people can maintain that infrastructure?
So great questions. The different partners definitely bring different things in. Some of them are very good with the data aspects. I think we have a lot. We have a lot to learn, and this project is going to present some real opportunities for us there, both in our cooperative, but also I think nationally, because some of the same partnerships that we've built exist elsewhere. Some of them are most of them are more limited in terms of the number of partners than we are, but nevertheless, it takes that sort of partnership. Let's see, there was the last part of the question that I really wanted to reply, the infrastructure piece, et cetera. What a lot of our, so that kind of goes back to what I was talking about, where it takes a while to build momentum. Practices kind of get engaged tentatively thinking, yeah, this is some research project, et cetera. And then they start seeing, wait a minute, they start connecting the dots around this. Part of it is we really have to work hard to connect those dots for the practices. But as they start seeing this as being fundamental work that they have to take on, they start looking for the next project. And that's where, unfortunately, we don't have funding for this kind of as a continuing sort of thing. We tend to go project to project, and to the extent that we can knit that together over time, we have practices that we see kind of repeatedly. They come back for the learning, for the technical support that they get, and they come back for the relationships, the ability to relate to and learn from other practices. And it just builds momentum.
That is really very true in the cooperatives that have had this trajectory going on a bit longer. I followed a coach of yours that has been working with some of the same practices for a decade. And part of what they think about at this sort of transition point is, well, what's the next study you have coming down the pike so we can keep working together? So I think they're definitely looking for, once they've gotten the bug, they're looking for that kind of longitudinal continued partnership.
But I'd say beyond just another study, are there other things they're tackling using
Well,
the tools and methods
So
in
just
their practice?
to be clear, and I've observed this as well, and I won't name names, but just because they're working on a study together doesn't mean that they're just working on a study together, right? So they want that continued relationship with the coach because they take care of things that they need for the study, and then they spend their other 3 hours that they have together working on how to change the communication culture in their practice, something that's really near and dear to their heart. Their coach helps them with that. So a lot gets done that's kind of invisible.
What I'm hearing you say is that without external funding, this work couldn't continue, and is that true? I think that'll be an important question to look at.
Yeah. Thank you. And I actually, I want to hear all this, but just really quickly, if you were going to advise right now, AHRQ, you heard we're touching 7 cooperatives touching 1,500 practices, building relationships, building infrastructure. If we had some money, would you rather see those cooperatives continue to work with those practices and go deeper and further, change the area, learn more about sustainability, do a different area, or get those cooperatives to work with 200 other practices who haven't yet gotten them? Politically, small p, just prioritizing. Is it better to ask these folks to move laterally or to go deeper? If you had to prioritize right now, who says fund these guys again, same practices, go further, learn more? And how many? And then if your other option is, say, keep this infrastructure going by asking them to spread it to people they haven't touched yet. I don't know if they would accept either. Actually, I have a feeling whatever we say, they'll be excited by it. But what do you think is the priority? And if you don't have it right now, if it hits you on the plane, let us know, because that's that kind of question. What's our next step? And or is it let these guys swim, find other other funders and other things, and get to Arkansas and California and Alabama, and yeah, to go to places we haven't yet touched. And I would love it if you get to Congress and tell us to do all of these things, but assuming that's not, help us prioritize.
I want to give just a quick response. When we first started this work, I really thought, we put a practice facilitator into a practice for a year. We get them to where they have instituted a good quality improvement process that they can kind of continue on and that they'll be able to sustain this. And some practices can. I mean, clearly we see some practices that are able to keep this thing going, particularly if the wind's right and they don't get deflected by a lot of other things. The problem is the winds oftentimes aren't right and they do get deflected by a lot, and it takes a while for them to get this really institutionalized in the face of the current environment. So I think it takes time. Practices really need a certain level of support. It does decrease and it changes over time, but it's hard for them to kind of completely keep their momentum going without something there.
Don?
So this is great. You don't even have to buy me lunch if I'm going to hear great stuff like this. And I'm really glad to see that the continued use of the extension model, which answered the question I asked previously. So I have one comment that's perhaps a strategic interest to AHRQ leadership, and then 3 small questions. The overall strategic comment is that if what you just presented, if encapsulated in a message to policymakers, if you could do that, that would be far more powerful than a lot of what is sometimes brought up to the front. These are states with rural populations, with senators who have equal votes in Congress with big states. And this is a real story about primary care and people and communities, and you almost got it. I mean, all the elements are there. I can see this in a 4-minute presentation that would just change a lot of perceptions on Capitol Hill about what AHRQ, especially the slide saying this is what only AHRQ can do, or if you revise things, this better be preserved in some way. So that felt very inspiring to me. The 3 questions, I don't know Colorado as well as I know New Mexico, but I was looking for you to say something about Project ECHO and leveraging telefacilitation. And I was also hoping that you would point out that Medicaid expansion was taken very seriously from New Mexico and may well be a facilitator for what you're doing, which would be a double whammy in terms of policy influence. So that's the first question. Secondly, there's an interesting, Deborah, a very interesting evaluation questionnaire. I'm not sure I get it. There's a spectrum between external evaluation and embedded action research evaluation. This seems like a blend. It certainly isn't heavily firewalled, and I'm wondering the extent to which you regard this as embedded real-time feedback research. And then the final question, there was a mention that you would evaluate the learning community amongst the, what are they called? Cooperatives. And I'm just wondering how that's going. I'm kind of frustrated by the use of a shared learning community for almost everything these days, and I don't see a lot of evidence that either the specs are well defined or we understand if they work. So I guess they're not such little questions, but anyway.
So I guess I do deal with the New Mexico, the Project ECHO. There's kind of separate related sort of efforts in New Mexico and now in Colorado. I mean, we've built a Project ECHO program in Colorado as well. And in Colorado, we're collaborating pretty closely around certain things. There are areas where they really help us in terms of some of the workforce development sort of pieces. We started trying Project ECHO within TCPI actually as a mechanism for doing essentially practice facilitation from a distant. distance, and it didn't quite work the way we thought it would. I know IHI has done, I think, a project around that. You know, one of the people who's working with us consulted on a project like that. I don't think we've completely, I wouldn't abandon it, because I think part of our issue there was that we were working with so many different types of specialties within a group that it was just hard to get them engaged in quite that format. So, but at any rate, I think particularly for our Colorado Sim project, they're helping us with supporting some of the integrated behavioral health specialists in the primary care settings and providing some trainings around mental health services for practices, some reminders to people who haven't really dealt with some of that stuff as much over recent years because they didn't have the resources. So I think it's an important resource.
Yeah, I can try to answer the other two questions. So as David mentioned, we have an independent funding stream, and I guess I sort of broke my teeth on this work in an initiative called Prescription for Health, which was funded by the Robert Wood Johnson Foundation, and was really fortunate to have a program officer for evaluation who you might know, Laura Levitin. And she made it very clear when we were evaluating that initiative that separate funding streams are absolutely critical, and that you can still be connected and be independent. Just because you are developing rapport with the folks that you're evaluating doesn't mean that you don't have the capacity for critique. And that's the space that we're trying to be in. Because if we just did an outcome evaluation here, there would be a ton that we wouldn't really understand or learn. And if we go into meeting with the cooperatives in a way that is, for lack of a more technical word, judgy and ivory towerish, we have to build rapport with them for them to share what they're really learning on the ground. And I think our approach and our motto has been, and we've more or less embodied this, is that we're trying to appreciate the work they do, the good, the bad, and the ugly, because there's more learned from failures or mistakes than there are from successes. Does it muddy the waters a little bit? A little bit, but I still think that we're outside of what the cooperatives are doing. I didn't have to recruit 200 practices, and there were many nights that I went to sleep very happy about that. I have to now deal with the data that comes from those 200 practices. So we really are separate from them in a lot of ways, and I think what you're hearing is a robust mixed methods approach that isn't always common in this kind of evaluation, that's really trying to build rapport in the way that community-based and participatory research does, so that we learn what's going on the ground and can connect it up with what's going on quantitatively as well.
And to help them with that, AHRQ really designed this as external and created the Technical Assistance Center and tried to help the community. And there are clouds of overlap, but overall, they get that the evaluator may even think they know the solution to a problem a cooperative is having, but tend not to volunteer that. They're not doing a truly participatory evaluation where they would be helping change the interventions. The TAC, on the other hand, who is non-evaluatory, is completely engaged in what are you struggling with? Let us help you find, either within this community or outside of this community, resources to change what you're doing. And then they let Deb know that they did that so that she's able to watch change.
And vice versa. When we see that a cooperative needs something, we will refer it to the TAC. It does get blurry at times, but we do our best to do that. The other question was around the learning cooperatives, and I think there's two different levels that is worth clarifying. So at the cooperative level, within each cooperative, developing learning cooperatives for the practices is one of the strategies that they're doing. It's one of the strategies that you're using. You've done it in Colorado and New Mexico. They've also done it in Virginia. They've had these kinds of learning cooperatives and peer-to-peer experiences across a lot of the cooperatives, and we've attended some of those. I think that they take some practice, they take some relationship building over time. The peer-to-peer experiences, it's been hard to sell those to providers and to practices who, they don't necessarily want to meet after hours to meet the clinician down the block. But what we've also heard is that when they do, they love it. So I'm sure, I don't give them food, but the
We-
cooperatives do.
Well, we can't with federal funding.
Yeah.
We have to, I mean, honestly, that's something that our department is footing the bill for because you can't do it without feeding them.
So that's one level. And then at the level of the initiative, I think that the PIs and other folks in the cooperatives are connecting. AHRQ and the TAC have developed a learning exchange where there is learning on a web-based platform, but there's also connecting through lots of different phone calls that are focused on common issues or concerns. So I sense that there's been that kind of collaboration at that level as well.
I know we have to move on. I really encourage you to write up the specifications of the nature of the evaluation and the learning community, because the literature is really murky and devoid of what I think is the way it ought to be done in implementation research. So that's a separate thing, and I'm
Yeah.
sure it would find an audience in
Yeah.
British Medical Journal
It's a
of
great
Quality and
point.
Safety or whatever.
Monica.
I was delighted to see you had a slide about connections to community resources and addressing the social determinants of health. Looked like that was only one boot that was on the ground. And so of the sort of the size of the teams that are necessary and the volume of the people and the magnitude of the behavioral change that's needed, and the fact that people live in their communities and homes, not in the clinic, so much of this work relies on the built-in social environment, social networking, fresh fruit, and like all of those things. I'm just preaching to the choir at this point. So I guess my question is, to what degree do you guys see this as potentially being a stepped thing, sort of thinking about if you had a longer term approach of trying to get your internal house in order first, get the practices, in shape before you move out to the community, but sort of transitioning potentially some of the resources to be more externally facing as opposed to internally facing if you had the time to be able to do so.
Yeah, I think they're somewhat simultaneous. Now, definitely some practices are not going to be ready to kind of look outward until they do some basic work. And so to a degree, there's a certain amount of practice transformation. They need to see the needs in there's some practices that get that just coming in, but most don't. And so it takes a little while to kind of start getting them to focus on population health and kind of the needs of the population. And then it kind of leads naturally into this. Again, I feel like if the people kind of there locally gets to know the practice well and can help to assess exactly where they are and when they're ready for really engaging, that will help. The other piece, though, is just getting the community house in order as well, because that's so fragmented. I mean, there's some work around health alliances that we're seeing in Colorado. They're kind of forming organically and just taking advantage of those, linking those in, linking new partners into it across a broader partnership. I think can lead us into being able to tackle the social determinants in ways that we just would not be able to do otherwise. So I think the real thing around being able to tackle social determinants on more large-scale efforts, it's just necessary to have that infrastructure. We're just now building it.
Yes, exactly my
So
point.
I agree, and I can give a couple bright spot kinds of examples where I think innovative approaches and thinking have already started to percolate up. So I went on a site visit out to a very, very rural part of Oklahoma and attended, as I showed you, they have these CHIOs, these community health organizers. And so I went to one of the CHIO meetings, and part of what Oklahoma did that I think was really clever was that for every CHIO that recruited a practice or a certain number of practice, they got $1,000 to put towards some community thing that they wanted to do in this particular community. And having stayed there for the night, didn't have any sidewalks and didn't have any place to go for a walk. And part of what this community struggles with is a place for their kids to play. So they write a federal grant and they get a place to plays with, and it gets run down, and then they need to write another grant to do that. And part of what they were doing was they were going to put their money towards, I forget the details of it, but creating an organization that could be not-for-profit, that cost $250. Part of their money was going to go towards that. And then the other part of it was going to start bringing together to do some planning about creating a place where folks can go for a walk and get some exercise. Another network, and this took a lot more work than I think they thought it was partnering with an organization called NowPow.
Oh, yeah.
Yeah,
It
so
came
you,
out of University
which
of
is really,
Chicago.
really neat, right? And so for those that don't know, they've got boots on the ground. They go to a city, usually high school kids,
Yep.
and they map all the community resources. They've got technical people, and this is the most millennial office place I think I ever worked in. It's a big barn with young people with headbuds in their ears or earphones on. And they get all these programmed in, but what their software does is it connects with the EHR, and it lets the clinician refer to a community resource in that person's neighborhood and then create a linkage so they know if the person went and they get some follow-up. And they've been in a limited number of places, and truthfully, they really struggled to get this off the ground in the limited time frame that they had for evidence now, but there's real potential, I think.
I mean, that was just my concern, is that that's a whole world in and of itself. That's
It's
more than one person.
It's a heavy lift.
And so just acknowledging the infrastructure, the human capital, the social networks, all of that needs to be in place in order to sort of make that happen.
Yeah.
But thank you.
But it's the place where this gets cool, right?
Yeah.
I mean, if you think about a time where there's a big divide between the urban and the rural, but this is where it comes together, essentially, you know?
David?
So I agree with Beth that this really resonated with our experience. So to answer your question about broader or deeper, I would suggest going deeper in the sense of you've invested in the infrastructure, and what the real critical question is, how do you make these efforts sustainable? You know, you're not going to have another $112 million again anytime soon. And the question is to how to learn from what the different groups have done in blending different funding sources so that when this project goes away, the ground regulate could continue. And then looking at sort of what the marginal cost of sustaining this is, looking at where there are returns on investment that could make, create a business case for it. I'm very interested in the qualitative work. We do a lot of facilitation in the VA, and there's very little known about what is facilitation. And I love that slide. I'm going to copy that slide about, what do the facilitators do? What makes a good facilitator? What does it cost to do facilitation? I think we're convinced that that's a critical part of helping these practices change, but it's very hard to tell somebody who's never hired a facilitator or what to do with it. And then I guess the one challenge I have, so the one thing that we probably don't resonate as much are the data problems, because we have common records. And I worry about projects where you spend a lot of the effort tackling something that's not an interesting issue. It's a real issue, but it's eventually going to get solved, and so I guess I don't want to be too glib about it. And so the question is sort of, what are the EHR and data issues that aren't going to go away when Epic and Cerner have 100% of the market? We're already going into one of those. So what are the issues that are still going to be there? Because you don't want to, spend a lot of time fixing issues that eventually someone else, the market, is going to fix, because that's not an interesting site. It's not a good use of scientific research dollars. But I'm sure you have a sense of there are issues that even when everybody's on the same record are issues about actually using your data for improvement that often get glossed over.
I think so. So smaller practices, I don't know how quickly smaller practices are going to be able to afford to go to systems like Epic and Cerner. They are also not, well, let's assume that they do, right? I think that two things come to mind. The first is that the design of EHRs is such that the same piece of information can be documented in multiple places. And the result of that is that there isn't consistency in documentation behavior. That then cascades to programmers who are then designing programs to tell the computer where to extract from. And oftentimes there are there's programming done that doesn't pull from all of those areas. That has been one of the major reasons why people find their data aren't valid. I'm documenting in box 4, and the programs are pulling from 2, 3, and 5. It's a huge problem, and I can't explain all the motivations for why that doesn't happen. One may be they don't know all the places to pull from. The other is it sometimes seems like these products are put out before they're completely fully baked. A third problem is the reporting software. It may be available in these EHR systems, but it is not easy to use. So if it is there where you can generate a report for any measurement period or look at any drill down that you'd like, there is not necessarily at a independently owned, smaller independent practice, somebody with the knowledge and expertise to use those reporting tools. They should be much easier to use. We were in a number of practices where they absolutely had them, but man, nobody knew how to use them because they're not so easy to use. Those are just 3 things that come to mind. I'm sure there are others.
So David, just to follow up, three quick points. First, on the EHR, we're trying to write those papers to start there. So we're going to try to get some of that out. And our intention was never to make this an EHR thing.
Right.
It did take too much of our resources. This program will not be as successful as it could have been because of this problem. And so the community said, though, we've got to document and tell this story because they couldn't do the work they wanted without solving it. So we're making the best of what we got stopped with, but we're with you. We wish we didn't have to do this. One of those unsung positive stories, New York City's cooperative went to a city meeting, and the city was excited about it and heard them talk about the problem that there was nobody at the practice who knew how to use the EHR, and by the time you trained that person, they moved. And they were continually having to waste money and time getting people up to speed. And the city said, we're going to create an EHR training facility that any primary care practice in the city of New York can use when they get a new person to get them quick training on how to use their EHRs for quality improvement and quality reporting purposes. So the city changed because of Evidence Now. Now that's a workaround, but it was still sort of cool to see. And the third point was that AHRQ actually has a fully developed curriculum for practice facilitation that's mirrored with a how-to guide for people starting. Do you want to have a practice facilitative program? How much does it cost? Where do you hire these people? What's a job description? How do you evaluate them? Really nice material. So I'm actually very proud of those. But the cool thing we're trying to do now is take all the knowledge these people have and pour that into the next version of our practice facilitation curriculum. So we hope that one of the enduring resources from Evidence Now will be answering for not just the VA, but anybody else who wants to ask, what would it cost us? How would we do it? What are our options? Do you want to hire nurses or do you want to hire community workers?
With an electronic health system, that the one you said, somebody said earlier, the one thing Democrats and Republicans, one thing every clinician agrees on is they don't like using it. It takes too long, and they're horrible. So
We're not
And
teaching
they'd never
EHR.
give them up.
Just to be very clear, we are not teaching people to use it, just facilitation. But take a look.
The other interesting thing about facilitation, and I think your cooperative speaks to this nicely, is that there's a quality assurance component to this that I hadn't really thought of, but it manifests beautifully in Colorado because they've got 20 different PTOs. And how do you assure that you're bringing a good product out to a practice? And I think there's been some really interesting lessons learned about how to do that in Evidence Now to complement the beautiful documents you guys have. They're really helpful.
Kevin,
And lunch, right? Yeah, so,
we're the only thing that stands between us and lunch.
I get that.
Use it wisely.
Yeah. Look, again, I mean, congratulations. Really impressive to see this kind of report on this. And I think, Gopal, I mean, it fits so much with what you started off talking about. It's translating evidence into practice. And it's also really the unique role of AHRQ in primary care, because there's really nobody in the space of really supporting this type of pragmatic primary care research that's not, that really cuts across whole person care. So I think this really should resonate where AHRQ strategizes about its strategic role. You asked like a pretty profound question, David, where to go with this. And as you know, I have an intimate understanding of the history of primary care coaching and the extension program. And the vision for this and the national policy was that there would be federal funding for practice coaches throughout the country. That didn't materialize. AHRQ, to its credit, said we're going to move forward with this anyway and put some money into at least getting this done in this way that this project, impact and now the evidence now represents. But David, I mean, you're going to have to think. I mean, there are limited resources. I really agree with David. I don't think AHRQ can support practice coaching on an ongoing basis. I mean, I think you have prototypes and you've had proof of concept. And for this to be sustained, it's really going to have who are the stakeholders that then will take on the responsibility of operating this type of practice facilitation work. Because I think you have to think, what is AHRQ's strategic role? And I think if with limited resources it continues to just say we're going to, I mean, if you're going to support them, they have to be then they're your test laboratories, because otherwise you have everybody else, the rest of the country, jealous that how come we're not getting these same resources. So I think you have to make the case about what are we learning that then could happen. And I think the next thing is say, who in Colorado, New Mexico, and Oregon, who's going to pick up the actual operational side of this? And then AHRQ layers on what it can do, which is probably largely going to be around the evaluation, the tools, the practice trainer, curriculum, things like that. But I think, you won't have the resources, as David is saying, really to do something of this magnitude again. And so my sense that's the strategic question facing you here. Or it is like Monica is saying, the next iteration is how do we really push it into the community connections and social determinant? What's the next question we want to answer and understand? Can this actually happen in an effective, efficient way?
So just as a quick comment, and Paul's here from CMMI, I think there's a great opportunity for partnership around some of the projects at CMMI. We don't know what the future of those may hold in terms of large-scale practice transformation support sort of programs to support moving into quality payment program and future sort of alternative payment model sort of stuff. But obviously they're making a large investment in this. And I think there is the potential for building off of those, were essentially being implementation projects that are being evaluated at a high level, but at a relatively high level, but using those opportunities for more refined research pieces tied into those. So just throwing that out, look at some of the other folks who are supporting this work and see how we can kind of find synergy, and some of those would be a nice thing from my perspective.
Quick thought, just triggered by this last discussion, that is, it seems to me that when we're doing system-wide interventions, as part of the evaluation, cost effectiveness has to come into it, because ultimately for its adoption by a system, it has to be, what are we gaining from this clinically, what are we gaining from this organizationally, and what is it we gaining from this financially? We all know that if you really want systems to try to change, even if they don't know exactly how to do it, change the way they pay. We get paid. Every one of our institutions is killing itself trying to learn more about how to take care of sepsis and prevent rehospitalizations because it's linked to payment. So without cost effectiveness as part of the formal evaluation, I think it's going to limit the adoption. It has the potential to impede the adoption diffusion of effective innovations. So just a comment. And they can be done quicker and dirtier. Not everything requires
Actuaries.
To belabor it if I can. But, Sharon, you showed the slide on hospital-associated complication rates. And AHRQ's had a critical role, I think, in helping with the data, the reporting, and things like that. But that was all predicated on hospitals had an infrastructure for implementing safety, right? You did not fund every hospital in the United States to come up with a safety team. And I think this is the predicament and the unfortunate situation of primary care. There is not that infrastructure. So I think you have stepped in there, but I think then you're going to have to say, what's our lessons from the hospital sector type? work in practice improvement, the culture of safety, and whether it's, the money is in CMS, whether it's payers, and frankly, there are meso organizations. I mean, there are clinic associations. I think one is going to have to say, how do we get this built in? What is the return on investment for the equivalent of the hospital, for the IPA, for the clinic system, in partnership with payers? And I think that if you can help facilitate that case, and I think that's Gopal, you told the multiplier effect, how we can learn from this and who should be picking up this, because what you could do in the role of AHRQ in the hospital sector here, and that was dependent on people investing in that infrastructure, in quality, safety, apparatuses within the hospitals that you just don't have in primary care. So who's going to own that in the long-term basis is the question.
Okay, so thank you for a terrific set of presentations and a very rich discussion. So you have 15 minutes to get lunch and be back here to continue the adventure. Thank you.